Hi, everyone. My name is David Landy. I'm an orthopedic surgeon specializing in hip and knee replacement with OrthoVirginia here in Lynchburg, Virginia. Today, we're going to talk about knee pain and more importantly, is my knee pain arthritis? What patients need to know. So we're going to start off by overviewing what we're going to talk about. We're going to talk about 6 things. First, we're going to talk about, what's in a knee. And then next, we're going to talk about, what is knee osteoarthritis, followed by is all knee pain from arthritis? How will you know if it's knee arthritis? What are the treatments for knee arthritis? And then finally, who needs a knee replacement? So first things first, right? What's in a knee? So there's gonna be some pictures here. On the left, this is sort of a side view of your knee. And then on your right, sort of a front view of the knee, like you were looking in a mirror. And there's a lot going on there, but I think it's helpful to break it down by, what does the knee do? So the first thing the knee does is load transfer, right? It takes all that energy when you're stepping on the ground and takes it from your foot and transmits it into your axial skeleton or your spine. And so to do that, right, a lot of weight going through that so that at the end of the bones, there's cartilage, which provides some cushioning to help to make that a little easier to transfer that load. Second is mobility or movement, motion of the knee. And so you've got these large muscles with muscle tendons inserting on the bones around the knee that allow you to straighten the knee and bend the knee. One of the biggest there is the quad muscle in the front of your thigh, which is depicted here. But then there's other muscles that insert around the knee as well that aren't depicted on these diagrams, like your hamstring muscles. And then finally, to do the motion and the load transfer, you need to have knee stability. And so there's ligaments on the inside and especially on the outside of your knee that help keep the bones sort of aligned up while you're trying to move and have all that load transfer. And those are highlighted here. So what's knee arthritis? Well, it's a progressive degenerative joint disease, typically just called arthritis. Another term for it is osteoarthritis. Affects over 20% of US adults. And then here's going to be a diagram. And so again, right here, you see that cartilage, that cushioning for the knee has been lost on the right side. And then as the bone no longer is protected by that cushioning, it starts to see unusual or increased forces. And then you see pathologic changes such as bone spurs, and eventually even you can start to see some deformity in the knee. So what can knee arthritis look like to you? Well, here is a picture, on the left side is a normal knee, on the right side is an affected knee, and there can be knee pain. And typically the pain from arthritis is not necessarily felt in the middle of the knee, but it's almost along the joint line, right? Where those lines are. And it's where you're losing the cartilage and you no longer have that cushioning. And so people will feel pain along the joint line. You can also get swelling. Here on the left side, you can see this nice dimpling of the knee. But as the inside of the knee starts to get really bad arthritis, it gets swollen and you get an effusion, and so you sort of lose that dimpling as the effusion is sort of pouching out the knee. And then as things get worse, you can see stiffness in the knee where you have a tough time straightening it all the way, or you can't bend it in as far as you used to. And then finally, some folks will even develop a deformity, whether it's a knock knee or a bow-legged type deformity, as they've lost so much cartilage on one side of the knee. So, is all knee pain in older adults due to arthritis? No, but a lot of it is. So what are some other things that can cause knee pain that's not arthritis? Well, patellofemoral syndrome, kind of also known as runner's knee. It's a little bit of a catch-all term for anterior knee pain that's kind of thought to be coming from a mismatch between sort of the strength and ability to move and extend the knee and how much you actually have. Tendinitis, right? All those muscles with their tendons inserting around the knee, those can become inflamed and you can get a tendinitis. Rheumatologic diseases can certainly cause knee pain, as well as hip and spine problems can cause knee pain as well. And then finally, meniscal tearing. This is sort of a thing that's commonly brought up and probably warrants its own discussion here on the next slide. So it's important to note arthritis leads to meniscal tears, and these are referred to as degenerative meniscal tears. When the meniscus is torn, you can have an acute tear or you can have these more chronic degenerative tears. And in these cases, the problem is not really the meniscus itself, but it's the underlying arthritis that led to the meniscal tear. If you look at patients with severe arthritis, 100% of them are going to have some type of meniscal tearing or pathology. Just as you lose the cushioning that's overlying the bones and the bones get closer and closer together, it's almost impossible for the other structures between the bones, like the meniscus, not to have some level of pathology. And usually treating the underlying arthritis is better, right? If the meniscal tear is just a symptom or a sign of the underlying arthritis, treating that's probably not going to be a great treatment. Rarely the tear can be so significant that it is treated, but again, that's rare, and you'll probably want to talk with your surgeon about that. Also important to note, arthritis can coexist with other issues, right? Just because you have knee osteoarthritis doesn't mean that you can't also have a tendonitis around the knee or patellofemoral syndrome, and they tend to coexist pretty frequently. So how do you know if your pain is arthritis? Well, symptoms, right? Where specifically are the symptoms in your knee? Are they along the joint line, or is it along a tendon? Exam can be very helpful, knowing if there's tenderness over the joint line itself, or if there's tenderness over one of the tendons. Again, is there swelling? Is the swelling an effusion, like it's on the inside of the knee, or is it more on the outside of the knee, suggestive of maybe a bursitis? And then x-rays are probably one of the most important things to diagnosing arthritis. Here's an example on the right where you can see the bones have clearly lost all their cushioning because they're touching on the x-ray and there's no space left there. That's what some people might refer to as bone on bone. And then you want to rule out other diagnoses, right? Sometimes it can be, there can be a couple things going on. And so you may want to get x-rays of the hip or other things like that to make sure there's not something else causing the knee pain. And then diagnostic injections. You know, we normally think of injections around the knee as being therapeutic or a treatment, but they can also be helpful diagnostically. If when the inside of your knee is numbed, it doesn't really help you, that might be a sign to look elsewhere for other pathologies. And again, you know, it's not always going to be a straightforward thing. And this is one of the things I like about, you know, seeing patients with knee pain is it's sort of a little bit of putting everything together, the patient's symptoms with their exam and their imaging, to make sure it all makes sense, and so that they can have, you know, the best sense of what's causing their knee pain. A common question we get is, shouldn't I get an MRI? The short answer is no, not for arthritis, but it's important to note that you do want to get the right x-rays. So here's an example where on the left, yeah, you can tell that patient has arthritis, but then when you get a special x-ray where they're bending the knee a little bit, you can see it's nearly bone on bone. And this is, again, another example where the x-ray on the left doesn't look as impressive. And then as soon as you take a special view, you can see it's pretty much bone on bone. So don't be surprised if you go and you see your surgeon and you may already have x-rays. They may want to get additional x-rays to ensure they're weight bearing in some of these special views. So what are the treatments for knee arthritis? Well, first and foremost, you know, over-the-counter medications like Tylenol and ibuprofen can be helpful. Physical therapy and low-impact quad strengthening have been proven to be very helpful. You know, it's not going to reverse your arthritis, but it can help give the knee a little bit more stability, which can reduce symptoms. Maintaining a healthy weight, possibly easier said than done, but can be very helpful in reducing the amount of load that's having to go through that diseased cartilage. Activity modification, right? If there's ways that you can do the activities you want to do that don't cause knee pain, then modifying your activities can make sense for some folks. Assist device use. This isn't going to be for everybody, but a cane or a walker can certainly be a part of helping take some of the load off that arthritic joint and reducing symptoms. And then bracing is another thing that some folks will find helpful. And then steroid injections are pretty frequently given and can help reduce the inflammation. Again, none of these treatments are going to reverse the arthritis. It's really all about symptom control and helping people kind of live the lives they want to. So what may not work for knee arthritis? What might you consider avoiding? Opioids, right? Yes, opioids might have a short-term effect, but this is a chronic problem. So starting opioids for knee arthritis is a bad idea and should not be done. Draining the knee, right? The problem is not the fluid. The problem is the underlying arthritis that caused your body to generate all that fluid. So putting a needle in there and draining the knee, while it might, in the very, very short term, provide some symptom relief, that is not a great treatment. Vitamins and supplements have not been really shown to work effectively long term and are not recommended. And then finally, stem cell injections. While the future, who knows what's going to happen, and maybe at some point someone will develop and prove a magical injection that does not exist now. And then finally, cleanup knee arthroscopy. There's probably a limited role for this in very select circumstances, but from an all-comers perspective, this is not necessarily a recommended treatment for arthritis. So who needs a knee replacement for arthritis? Well, it's really a quality of life issue. And it's reasonable to consider a knee replacement and non-operative management. So all those things we talked about a couple of slides earlier are not working, and your quality of life is limited. And it's really about balancing the potential benefits of the knee replacement versus the risk. Okay, so what is a knee replacement? Well, essentially, there's 1 million performed annually in the United States. You might spend the night in the hospital or even go home the same day of surgery. And then what happens is the ends of the bone where the cartilage is diseased, those ends of the bone are cut off, and then they're replaced with metal caps that are usually cemented in place, though sometimes they're just hit in place really hard and the bone is meant to grow into the pieces. And then there's a plastic piece in the middle, or a spacer, or an insert that's put in there. The recovery from this is in stages, but usually 80% plus of the recovery is in the first 3 months. Though it's important to know people will continue to improve up to a year. All right, so thank you. And are there any questions?
Thank you so much. There are questions. We will start with a question of, what is a diagnostic injection? You mentioned it in your presentation and people were a little confused.
Yeah, that's a great question. And so, injections can have more than one purpose. Typically we think of them as being therapeutic, meaning that the hope is that whatever's injected into the knee is going to lead to some kind of longer term symptom relief. But when you look at the steroid injections that are being given, right, very little of what's injected is the actual steroid, and most of it's actually a numbing medicine. And so for the first 4 to 6 hours after the injection, paying attention to your symptoms and whether that significantly improved the pain in your knee can be an important clue as to whether the source or the etiology of the pain in your knee is from inside the joint or outside the joint. So a lot of those tendons and everything like that help move your knee, right? Those are outside the knee joint itself. They're in the knee region, but it's outside the joint itself. And so you wouldn't necessarily expect an injection inside the joint to help, for instance, with tendonitis. And sometimes we will even inject around the tendons to see if that helps. So the purpose of a diagnostic injection is to see if it helps with the symptoms.
Thank you. Does arthritis change the shape of your knee and your leg?
It can. So what happens is for instance, in the knee, the most common pattern of arthritis is the cartilage on the inside, or the medial aspect of the knee, wears out first. And so then the knee can start to basically become a little bit bow-legged, and the knee, as things get really severe, can start to drift in. And then that stretches the ligaments on the outside of the knee, like your lateral collateral ligament, and the ligaments on the inside of your knee, or the medial side, your medial collateral ligament, can get very tight and stiffened.
Thank you. Is it ever too late to have replacement surgery?
Yeah, that's a great question. The short answer is no. There have been some pretty good studies looking at patients in their 80s and 90s who have had knee replacements, and they tend to do very well. There might be slightly higher risk of some small complications like urinary tract infections and slightly longer hospital stays. So instead of 0 to 1 days, maybe 1 to 2. But patients tend to do really well. I think it's important to consider, though, especially as folks get very, very old, there is at least a 3-month recovery from this surgery. So making sure that everyone sort of has the appropriate perception of what the benefits may be is helpful.
Thank you. How do you decide when it's time to have a knee replacement?
Yeah, it's a very sort of personal decision. And it largely depends on having exhausted non-operative strategies. So having tried things that would be lower risk, and then how much is it bothering your quality of life? And that's where I think some of the nuance also comes into play too. and having a sense of what proportion of your symptoms are from your arthritis versus other issues. And, as best possible, trying to understand what the real benefits might be, right? If you've got knee arthritis, but you've got 2 or other things limiting you, making sure you realize that a knee replacement is going to help with the symptoms that were from your knee arthritis, but it's not necessarily going to help with your back or something else.
Thank you. Is there a way to prevent arthritis in the first place, or if you have arthritis, prevent it from getting worse?
Yeah, that is a very good question. Really, weight management and maintaining a healthy weight is probably the best thing you could do. Other than that, though, there's not a lot. A lot of this is probably genetic, underlying why some folks get arthritis and other patients won't. There were some studies done that looked at, well, should you avoid activity? Will that slow it down? The answer is no. People were also interested in the idea, maybe if you force people to be active and walk on it, it'll kind of stimulate the cartilage to do better. That didn't really matter either. So do what you want to do, but don't think it's going to help or hurt your arthritis.
Thank you. If someone has arthritis, but their knee isn't actually painful or bothering them much, do they need to still take action?
No. If again, all of those non-operative strategies were designed around symptom control. So if you don't really have any symptoms, there is really not a lot to do. I mean, there are some maybe rare exceptions, but 99.9% of the time, this is about symptom management. So even if someone says, oh, you have arthritis on x-ray, if it doesn't bother you, just keep doing your thing.
Thank you. Is bursitis a form of arthritis?
That's a great question. No. The knee can get really swollen, and sometimes you'll get a Baker's cyst where some of the fluid from the inside of the knee leaks out, and you'll see a lot of swelling in the back of the knee. But that is a little different than one of the bursa, or these little fluid sacs that are designed to sort of cushion tendons from being inflamed. So folks can have a prepatellar bursitis, which is a swelling we can see around the knee, and that is different than arthritis. Though much like everything, they can co-occur. So someone can have both knee arthritis and prepatellar bursitis, but the treatments would be different.
Thank you. Are there any exercises you recommend to help people either before they need a knee replacement or when they're waiting for a knee replacement?
Low impact quad strengthening, so that big muscle in the front of your thigh can be very helpful. So things like a bike, riding on a stationary bike and really working on that quad muscle can be very helpful. And that's why one of the more proven non-operative treatments for knee arthritis is physical therapy. And the real most important part of that physical therapy is low impact quad strengthening.
Thank you. We asked about if it's too late to get a replacement, but is there such thing as too early? How young do you have to be to get one?
Yeah, that is a very good question. And unfortunately, there's not a very good answer. I would say, there's no age cutoff. Certainly, I've done knee replacements for folks in their 30s. Ideally, you would wait as long as you could, but, sometimes folks will have arthritis from a post-traumatic issue, and they'll get it very early. And then, there's a chance the knee replacement will wear out if they live long enough. But if you're disabled enough, then it probably makes sense to consider taking on those risks earlier. One thing we'll often talk about is if you had to pick being able to walk and be active in your 30s or 40s versus your 50s or 60s, I think a lot of folks would pick their 30s and 40s. And then you just, you take it how it is.
Thank you. Several people asked about pain either just on the inside or just on the outside of their knee. Is that from arthritis, or can you not tell?
It depends. It can be, typically the pain that we're least likely to want to attribute to arthritis is when it's just on the front part of the knee, like right over the kneecap. That pain often is more related to a patellofemoral syndrome or something like that. Whereas if the pain is sort of along the joint lines, so a little bit medial or a little bit lateral, not a guarantee that that's from arthritis, but that does tend to be where patients with arthritis will more specifically point.
Thank you. If someone's knees are stiff in the morning or after they've been sitting a while. Is that possibly arthritis?
It could be. It could be a symptom of arthritis, for sure. Again, and this is where putting together the symptoms with the exam and the x-rays is very helpful.
Thank you. How long does a knee replacement last?
Yeah, that is a very good question. We usually say at least 20 years. I think there are a lot of factors though, right? If you're older and less active, 20 years may be a lower estimate. And if you're younger and heavy and very active, 20 years may not be as long as it lasts. And so it depends. I would say they last long enough though, that is not typically a huge driver of the decision as much as it used to be. One of the fastest growing segments for knee replacement is patients in their 50s. And a part of what's driven that is the implant survival is pretty good.
Thank you. How soon can someone have a second knee replacement?
Oh, that is a very good question. There's no one answer to that. I tend to wait 3 months because, at 3 months, you won't have caught all the complications you could possibly have with knee replacement, but you will have caught most of them. And so I usually like to wait 3 months. What I tell you though is the recovery, a knee replacement and a hip replacement are different. The point of this talk is not a hip replacement, but knee replacement's a little slower recovery. And no matter how many times you tell folks that, when they live it, they're like, oh, wow, this was a little slower. And so I'd say often the most typical time frame is a year. It's usually about a year out, people are completely recovered and they sort of forgot how slow it was to recover on the first one, and then they're ready to go for the second one. But yeah, you could do 3 months or even sooner. But I tend to want to wait 3 months.
Thank you. Someone is talking about their knee replacement sort of popping when they do things like ride a bike. Is that normal or something to be concerned with?
If it's painless, it's probably normal. There's different designs that probably goes beyond the scope of this talk, but a painless sort of click or pop with some of the designs can be a normal part of how that's working. And often over time, people quit noticing it, but some patients just always notice it. But if it doesn't bother you, that's fine.
Thank you. Are knee replacements covered by Medicare?
Yes. The short answer to that is yes.
Thank you. Why does someone have pain in their knee after a knee replacement? Do they just need to wait longer?
Yeah, that is a $1 million question. If you look across the country at everyone who gets a knee replacement, and this is assuming they get it done by someone who's fellowship trained, high volume institution, about 10 to 15% of people are not completely happy or will still have some level of knee pain. And there's different theories for that, why that is. Some of it may be that a knee replacement, those implants, that's not a real knee. Some of it may be there's aspects about how we put the implants in that we don't completely understand, and maybe there's a better way for some patients to be putting them in. And then, in my opinion, a big part of it's probably that there's other things that go on in a knee than just arthritis. And so if your symptoms are from a weak quadricep muscle or from a tendonitis, there's no reason to really think that a knee replacement was going to help with that. And so I think it's probably a mix of all of those factors, but it is important to know that there's this 10 or 15% of patients who will have a knee replacement, and there wasn't necessarily anything wrong with the way the knee replacement was done. They're just not, unfortunately, completely satisfied. And that's the other reason why you really want to make sure that when you get to the point of having a knee replacement, that you've maximized sort of non-operative strategies and that your quality of life really is limited to help weigh the risk and balances, or risk and benefits.
Thank you. You spoke some about cortisone or steroid injections. Can you talk about gel injections?
Yeah, we'll briefly touch on that. So gel injections are recommended against. That recommendation, though, is largely like a societal recommendation. It's not like anything bad happens to individuals who get gel injections. They're very expensive, and most of the data has shown that they're not really any better than steroid injections. I think for folks, though, who aren't ready for a knee replacement and have tried steroid injections and the injections weren't kind of as good as they were hoping, there's probably not a huge downside to trying a gel injection. With that said, right, there's 1 million knee replacements a year in this country. 20% of adults in the US at some point will get treatment for knee arthritis. So it also probably doesn't make sense as a first line treatment either, just from a societal standpoint.
Thank you. Do you recommend heat or ice for knee pain?
Whatever you find comfortable. Some people will find ice, some people will find heat. Really, this is just about symptom control. And so even if it's something that is not necessarily proven, like a neoprene knee sleeve that you can get at Walgreens, if that makes you feel more comfortable, then it doesn't matter if it helps the next person. If it helps you and it's zero risk, it helps you.
All right. Thank you so much, Dr. Landy. That is all the time we have for today. Would you like to close?
No, thank you everyone for coming. And I think the most important thing is obviously a lot of what we talked about is a broad overview. And certainly if folks have specific questions, you should probably go in and see your doctor or an orthopedic surgeon.